of competency-based education. That is to say that achievement of a competency really amounts to walking up a smooth curve, so sort of one of those asymptotic kind of curves. At some point, there's some predetermined level of competence. When the resident achieves that level of competence, then he or she can go on and do something else. And that's the basic idea. That preset level of competence is called an Entrustable professional activity, or for those of us in the know, it's an EPA. And the obvious thing is to suggest that different people are going to achieve different competencies at different rates. And that our role as a program should be to track those competencies and track the achievement of those competencies so that we don't have residents hanging around doing stuff that they don't have to do because they're already competent, nor do we turn people loose who are not competent. So far, so good. So to just push this a little bit further, this is the way the ACGME is thinking about it in the States. An entrustable professional activity is a critical unit of professional work to be entrusted to a trainee once they've achieved a sufficient level of competence. They should be observable and it should be measurable, and then once they've achieved that, off they go. And there's just a lovely curve right from one of the graduate medical education papers that basically shows that different levels of competence and different competencies are achieved at different times, and at some point they all cross the axis, or in some cases don't, like that. It has attracted a huge following, this whole idea of competency-based education. This is the Carnegie Foundation report, which was billed as the successor to the Flexner report of 1910, 100 years later. And they jumped on the bandwagon thoroughly. Adoption of OBE would better equip graduates to respond effectively and efficiently continue to expand the depth and breadth of the requisite competencies. Another writer in the early days, OBE is an intuitive approach that engages a range of stakeholders. It encourages a student-centered approach and at the same time supports the trend for accountability and quality assurance. It really has taken the world by fire. There's been massive promises made of this. This is billed as the sort of the biggest revolution in graduate education and in medical education for a very long time. And it's taken over the world. The Scots developed their set of competencies sometime around the year 2000 and something or other. The U.S. had the ACGME Competencies. The Brits had Tomorrow's Doctor. And we had CANMEDS Roles. And CANMEDS Roles, well, just to give you a sense as to what these things look like, here's the Scottish doctor. And that looks all perfectly reasonable. These are the things that the Scottish graduate should be able to do. And that's a plausible list. Nice short list. And there's the ACGME Competencies that again seem to ring true, systems-based practice professionalism. It's nicely broadened beyond simply medical knowledge, which is one of the attractions. In fact, the CANMEDS Roles really goes further and says the center of the daisy, and they refer to it as the daisy, is medical expert, but there's all these other non-medical competencies: communicator, collaborator, manager, health advocate, and so on. And that students, graduates, should be competent in all of these domains. For some reason which defies understanding, the CanMEDS Roles have taken the world by storm. So far, 26 countries have adopted the CanMEDS Roles. It's been implemented in some shape, form, or fashion in all residency programs in all universities across Canada, and in the Netherlands, and in Mexico, and in all sorts of places. So far, so good. Except that as I looked at it as an educator and as a measurement person, it seemed to me that there were some fundamental flaws out there. And here's the nature of the flaws that I'm going to look at. One is those 7 little roles aren't quite the 7 we make them out to be, and when you start to unpack them, it gets really complicated really quickly. Secondly, ironically, although it's identified the softer competencies like professionalism and communication, arguably because it has to be framed as a measurable competency, it might actually give short shrift to those competencies. Third is that lovely curve that they keep drawing, as I'll show with evidence, is massively simplistic. It's not like that at all. That's not how learning proceeds. And that makes it very problematic to say when somebody's achieved some particular predefined level. Related to that is that sampling is a ferocious problem. We know that, when we've known for decades, that anything we care to measure in a physician's competence is tremendously variable from one encounter to the next. It takes an awful lot of observations to be able to pin these things down with any precision. And that represents a serious problem when you're trying to say that that curve just asymptoted through the dotted line right about now. And I'll show you some examples of that. That then makes the assessment problems much bigger and much more difficult than we thought they were going to be. And finally, we'll talk a little bit about the logistics, although that's not my field. And of course, I'll ultimately end on a high note and suggest that maybe if we take this with many grains of salt, it's maybe not such a bad idea in a kind of a tuned down version. Okay, here we go. Let's look at objective proliferation first. What happens is you take those 7 or those 8 or those 12 major competencies, and then you set task force to work across the nation, representative of everybody. Air Canada smiles as their bottom line looks better and better. And they sit there and they develop sub-competencies. And then for each one of the sub-competencies, they develop sub-sub-competencies. And pretty soon you've got a whole lot of sub-sub-competencies to contend with. But then you find that that's still not good enough in order to do anything measurable. So here's the CanMEDS Roles, and this is actual data on, there's the level 2 sub-competencies for each one of those things, and there's 28 of those that we now have to measure on every resident every 3 months. But that's not the full story. There's the level 3 competencies, and there's 126 of those, and we have to measure those every resident every couple of weeks for every sort of months, every 3 months. And that's true for all of them. The Scottish doctor, they've gone through the exercise. There's 86 sub-competencies. The ACGME in internal medicine has identified 142 sub-competencies. But unfortunately, we're far from done. Here's my favorite. This is the sub-competencies for CanMEDS Roles something or other. The one I really like is 6.3.1. Describe principles of learning relevant to medical education. I've been doing that for 40 years. And suddenly we're going to knock that off as a sub-competency as if there's nothing to it. Any one of those is a PhD at least. And we're somehow supposed to assess all 126 of those in an ongoing fashion. Here's a similar problem from the Scottish doctor. Take a history from patient, take a history from patients, relatives, and others for all age groups. Let's see, 5 age groups. Multi-ethnic, how many ethnicities? 200, there's up to 1,000. A wide range of different contexts. Well, let's throw a factor of 10 in there. That makes 10,000. Patient-centered is, oh, and by the way, history of something. How many diseases are there? 3,000? Well, that's 10,000 times 3,000. That's 30 million histories we have to look at. I'm being facetious, of course, but I'm not being facetious if we're really trying to meet the goal of saying, here's Joe walking up the curve of this competency. There, Joe just passed. It's not facetious at all. It's deadly serious. Because it has to be at a greater level of specificity than even that to be identifiably measurable. Being able to take a history of chest pain from a Scot is simply not the same as being able to take a history of fibromyalgia from a Serbian. It's just not the same. And you can't generalize from one to the other. So how many of those things do we have to assess in order to be confident that a resident has achieved what we had set them out to achieve? Here's another one. The ACGME competencies. Ability, this is at the sub-sub level. This is one of the 142. Ability to perform and interpret common laboratory tests. Trouble is, another committee of the ACGME has decided there are 39 common laboratory tests. So that's 39 for each one of 142. You can see the numbers get really big really quick. I worked it out on the back of the envelope a couple of months ago that if you take a reasonable estimate of how many competencies there are and how many observations you'd have to make of each competency, for a medium-sized residency program, you'd basically have to take about 150 million observations, which is half the population of the U.S. We seem to have a measurement problem. But this is just at the sort of top level of definition of competencies. A second thing is that, as I indicated before, there's no evidence of, well, there is some evidence we'll get to. But because we're trying so hard to objectify the competencies, stuff like performing a history or ordering a lab test is easy. Stuff like exhibiting professional behavior or showing good communication skills is really difficult. And what tends to happen, as I'll show you with data, is that the softer ones, although they're explicitly there, get short shrift. Supervisors avoid measuring them. They're not clear what they're measuring. And so paradoxically, although one of the purported advantages of this is that it's going to pay more attention to those things outside a medical expert, In fact, because of the demands for objective measurement, they may pay less attention to the things outside of expert. Okay, so those are right from the get-go. These are problems with the way you define the competencies from the outset. Now let's start shifting over to measurement. Remember that lovely smooth curve that I showed you? Is that really the way the world works? First of all, you have to recognize from the get-go if we've got a dotted line in there somewhere as we go up, if there's our level of competence, we're trying to measure the difference between two lines that are getting awfully close to parallel. And that creates a really significant measurement problem on the x-axis, because what we're trying to do is say, at what time did Jeff become competent? And that gets really, really hard because Jeff's line is crossing some dotted line at a very shallow angle. And there's the curve you've seen before. First of all, it's not that easy to figure out where the dotted line is. That's not as easy as straightforward as it seems. Here's one of the original studies that defined the whole idea of EPAs, Entrustable Professional Activities. All they did was take 14 activities out of the possible 126 or whatever the number might be, and ask medical students, so, have you got there yet? At what point do you think you would be able to achieve that, or where are you at that level? Where are you on that particular competency? Not able to do it yet, able to do it under supervision, and so on. They did that for medical students, first-year residents, second-year residents, and their supervisors. And they had 10 simple, definable, finite clinical activities: drop an examination plan for a new patient, treat a skin laceration of about 4 centimeters. Boy, you can't get much more specific than that. And 4 general activities like write a case report. And then they analyzed the data in terms of those ratings that individual students and residents gave to each one of those competencies. Well, the first thing it turns out is that the competencies aren't that separable. We do a factor analysis and we show that it's just one big competency. Everybody says about the same thing about everything. So the notion that even a resident or a student would say, well, I'm going to achieve that one early and this one late, doesn't seem to happen. Every time you look, you see a single factor in the factor analysis, and you see an alpha coefficient. If you get into the details, that's too high because we're trying to be measuring independent things, but they're all correlated 0.8 together. The second issue, though, is that the students and the supervisors don't agree. There's the specific competencies, and that's the student line saying, hey, we're doing a heck of a lot better than the supervisors say we're doing. There's the general competencies. Again, the student line is consistently above the supervisor line. And to show you that when you translate that into different points on the x-axis, things get really messy. That means that the students are saying, I'm done about halfway, just before I start into this first year residency. The supervisor is saying, no, you're not done for another year. And that's true for both the general and the specific competencies. So that's still at the level of simply defining the ecology, if you like. That's at the level of saying, here's the competencies, here's the point of EPA, Entrustable Professional Activity, for those competencies. And even at the level, that hypothetical level, we have problems. Well, what does actual performance look like? Well, even for simple behaviors in controlled settings with multiple measurements, the curve ain't all that smooth. Well, here's a more complicated behavior. This is looking at colonoscopies, and it's looking for something that the computer dumped out for them called the cecal intubation rate. I don't know what that is. I don't want to know. But they did it for 297 residents and 36,730 colonoscopies. 36,000 colonoscopies, 300 residents. Unfortunately, the computer was dumping that out because that means we didn't have to have a gastroenterologist watching all 36,000 for this one residency program and this one skill. But that's what the curve looked like, and that's, as I say, the average over 300 residents. And that's the average over 36,000 competencies. And there's a heck of a lot of wiggle there, and in particular, if that's the EPA right there, the time when we're going to let them go, well, that comes in on the one side of 234 colonoscopies, on the other side of 290 colonoscopies. Oops. Well, maybe that's too complicated a task. Maybe we have to sort of develop subtasks. So let me introduce you to a subtask that's been used in kinesiology and psychophysics since 1952, called the pursuit rotor. You can imagine this thing. This is some kind of undoubtedly an oak wooden box with a bake-like plastic disc in it and a brass little disc inside the big plastic disc. And the thing goes around. And all you have to do is take a brass rod and hold it on the little brass disc. That's all you have to do. And you're going to learn how to do that. And what we're going to do is time what proportion of the time you actually have the rod in touch with the disc, so you've completed the circuit. Okay, here we go. Here's the graph for 39 subjects in two groups. One group where they did it on separate sessions, distributed, another one they did it one right after the other. You record the time when the pointer's in contact with the disc, and you do that, and every trial is only 10 seconds, so you can rack up a zillion trials really quick, and we can see how smooth the curve is. Again, this curve is averaged over 40 subjects at each one of these points in time, and each one of these points in time gives you an awful lot of data for each one of those curves. Well, the first observation is that that's the distributed practice, and that moves up more than the mass practice. That means that how competent you get depends on what kind of practice schedule I arrange for you. That's a little problematic. The second thing, though, is that it ain't a smooth curve, particularly when you look at the mass practice, that essentially you start off high and then you drop off, and then you start off back down a bit, and then you come back up again and you drop off, and it has this, every time you look at it, every session has this hockey-shaped curve about it. So where is the EPA? Again, I can play my games and draw a couple of lines through there and say, depending on where I draw it, you're either competent at 48 trials, 60 trials, 108 trials, or 145 trials. That's a bit like saying you're either competent at the end of first-year residency or second-year residency or third-year residency. We're not sure which. This seems to me like a measurement problem. But that's a simple task. We've got a whole bunch of tasks to do. Anyway, you could say, yeah, but residents don't have to hold little brass pens on little brass discs anyway, so who cares? So now let's look at some real data out of McMaster's progress test, which shows that same characteristic, not so smooth curve. Okay? So here's, in case you don't know about the progress test, this is something that's administered to undergraduate medical students here. They do the first one 3 weeks into the program, and they do the last one about a month before graduation. They do a total of, they do 3 a year for the 3 years. Each test is 180 multiple choice items, sampled from a test bank of 3,000. So the first time they do it, they get an average score of 12%, because everybody's sitting the same exam. First year, second year, third year, they're all sitting the same exam, and then 4 months later, another exam, and 4 months later, another exam. First time they do it, they get 12%. Last time they do it, they get about 60 or 70%. And then they just step up the curve, and we use that to identify students who are having problems and are falling away. So what I'm going to show you is the curves for those examinations. Well, here we go. That's the curves for McMaster. The only thing is that's an average. Each one of those points is an average over about 200 students and an average over 180 test items. And there's still that much wiggle in the points, so that you can see that where I draw the line of competence again is going to be very, very dependent on whether I pick the top point or the bottom point. It really matters. And yet that's not a single observation of a single resident. That's 200 students and 180 questions. And you're still getting that amount of wiggle. Well, let's see. This is a single class, I think, and again you can see the wiggle. But what I haven't shown you is what the individual students' trajectories look like. Right? Because that's what we're after, is not how the class as a whole did, but how the individual students did. Oops. Walled and messy. And here's a few individual students in there. And here's the trajectory for a few individual students, and that's getting pretty wiggly too. So what all this suggests is that measurement issues continue to multiply. It's getting worse and worse. Okay. Now these are all, if you like, metaphors. These are all different situations which are not the situation we've really come to confront here. So I'm now going to flip to looking at actual assessment of CanMEDS competencies in actual studies done in residency programs. Okay. There's two ways you can go about it. One is to go back to those original 7 roles and say, okay, we're just going to assess how good you are as a collaborator, as a communicator, as a manager, as a medical expert, and so on. Or the second is you can try and go micro and identify each one of these individual competencies and see how well they can do there. Those lead to different conclusions. So the macro version is to look at general competencies, and that's what some people say you should do, that you shouldn't be looking at the micro level. You just give them an overall score on it, on the big picture. Well, let's see what happens. First of all, let's look at the micro level and the macro level. So there's one study looking at venipuncture, direct observation of venipuncture, or suturing, or something like that. And we'll look at that study, and then I'm going to look at another couple of studies where they just try to assess the 7 competencies, which is what the Royal College recommends you should do. Okay, so here's the first one. This is a study done out of Toronto with 6 observed stations looking at clinical radiographs and a single procedure. Now, the interesting thing about this one was that these were 39 residents who were all put through the same training program. They were all trained on the same procedures. None of them had encountered those procedures before. And first of all, you see a lot of variation, but secondly, what you see is that there's actually variation across years. That in fact, that even though it's the same training program, you're getting variations that somehow the first years are systematically worse than the third years. That could be okay, but what we don't know from those data is the extent to which each one of those observations, we don't know the reliability of those observations. If we had the same resident come back and do it again, we don't know how variable that would be. So that variation could be real variation, in which case it'd be nice, or it could be error variation, in which case it's not nice. But what turns out certainly is that although some junior residents outperformed some senior residents and fellows, the fact of the matter was that given the same training program, you're getting other sources of intrusion. So you can't just separate one competency and say, this is how Joe did on this competency, because it depends on other factors which they haven't measured. But maybe that's okay. What gets more problematic is when we try to assess CanMEDS roles directly. So this is an attempt to measure CanMEDS roles completed by a trainer over successive 3-month periods with 68 trainees. Okay. A bunch of things happened. First of all, some of them never got there. It's roughly 20 to 30% of the residents didn't improve over successive 3-month intervals. So I'm not sure what we would do with them. Although overall the change over the 3 months wasn't so bad. But the kicker is this. These are supposed to be separate competencies. The whole point of the exercise is to identify specific competencies and say, here's how you're doing on this one and here's how you're doing on that one. But when it comes time to assess those competencies at the end of the 3-month period by a supervisor, the internal consistency, the correlation between any rating and any other rating is far, far, far too high. Now, we've known that about these kind of forms for about 40 years. We know that when a supervisor fills out a form on somebody, basically what they're doing is saying, "Yeah, he's pretty good. Not very good." And they cannot particularize history taking from physical exam, from communicator, from collaborator. Essentially, the goal of trying to develop separable, independent competencies and then assess them just can't be done in that kind of format. Supervisors are not sensitive to those individual nuances. So here we are setting off to develop all these sub-competencies, whether they're 7 or 700, with the hope that we can individualize them and treat them as separable, independent units of activity, and we can't. It's as simple as that, we can't. So in a sense, the whole house of cards comes tumbling down. Another study by a couple of McMaster folks, Kevin Eva and Glenn McGarr, same sort of thing. This is the way the Royal College specifies it now, that you have to fill out this in-training evaluation report with the 7 competencies. I can see somebody nodding their head here. Yeah, there's 19 items and there's 5-point scales, and they did it with 63 residents, and they did 9 rotations over the whole 2 years. This is the 2-year family medicine residency, I think. Now, the thing is, each one of those summary forms is supposed to say, did Sally pass pediatrics? Did Sally pass psychiatry? How did she do in psychiatry? How did she do in pediatrics? It's the only game in town, right? It's the only game in town. So that's the final determinant whether she goes on to the next unit or not. Well, same story. The reliability is 0.11. Supervisors contribute more to that observation than residents do. And again, here we go again. There's two factors. The first, it's a one-factor solution. All they're doing is saying overall is she a good resident or not. It's unable to discriminate amongst residents. It's unable to discriminate amongst competencies. It's just a lost cause. Basically, I wish the Royal College would listen to us. We've known this since I was a puppy. These kind of summative assessments, as one of my mentors used to say, is if the resident doesn't pick his nose or drink his bathwater, he's above average. And that's the way the competencies go. And you can tweak the form all you like, and you can do elaborate things like talking about EPAs, and you've changed everything, but you've changed nothing. Those kind of summary judgments, everybody's always above average. But we continue to create these piles of paper, or maybe they do it electronically, but that's not going to change anything either. But the fundamental notion that we can encapsulate competence into individual and independent competencies, which can be individually assessed with the precision that you can say you're done now early or you have to go longer, just simply is a fool's paradise. Can't happen. We're not done. So maybe the solution is to do it in a much more real-time phenomenon. And this is John Sherman, emergency doc here. Instead of trying to do it at the end of the 3 months where nobody can remember what happened, after all, what did you have for dinner 3 days ago? I don't know. What you can do is say, let's watch you with the patient today. And what he did is something quite unusual. It's a 4-week rotation, 155 medical students. Each student had to get about a minimum of 10 of these little observations. That's been in the medical program for some time now. But what the evaluator could do was they had to assess medical expert, and then they could pick 1 or 2 additional of the 7 competencies at their choice. So it was, they could do the whole thing if they wanted to, but they had to do medical expert and they had to do at least 1 other. And the issue is, which ones did they pick to do? Well, let that cat out of the bag, didn't I? Medical expert, of course, 100% of the time. Communicator, well, I'm talking to you, so I guess I can assess your communication skills. That's 70% of the time. Professional, well, okay, 50%. And then there's these. Remember I said that from the get-go that one of the things that paradoxically might occur from this is that these softer competencies, in fact, get ignored, even though they're explicit, because we can't make them precise enough to assess. And so the supervisor is given the option of avoiding them, take that option. And they're all being assessed by less than 20% of the time. The second really worrisome thing is we then do an analysis of variance of this and say, so how much of the variance in those observations is being accounted for by differences between students? Because that's what we really want to care about, right? Well, 67% of the variance is due to differences between supervisors. 20% is, no, 10% is due to differences between students. Another is 3% for item differences, and then 20% for just noise in the system. So what you're finding out from those ratings is an awful lot about the supervisor and very little about the student. So who's not depressed? Okay. A single rater's rating had a reliability of 0.12. It would take 17 ratings to get an acceptable reliability of 0.7, and that's for a single observation at a single time point. Remember, we've got to get that smooth curve up there. We've got to do that for every time point. And that's only for 1 competency. We've got to do it for 7 competencies or 186 sub-competencies. And here we go again. All supervisors are capable of is essentially identifying whether Joe's a good guy or not. It seems counterintuitive. After all, the average supervisor probably spends several hours every day with that student, with that resident, but somehow it's really, really hard to sort of say, and how is their collaboration skills? What evidence do I have around their collaboration skills? And the way we're hardwired is just to make general impressions. We do pattern recognition by default. And so for us to particularize and make comments about collaboration skills versus professionalism just can't happen. So that's the horror story. In that case, Supervisors steer away from doing assessments on anything other than medical expert. Even if they do, it's not discriminating between the roles, and it's not discriminating between the students. All we're doing is finding out the differences between nasty and nice supervisors. That's what those measurements are giving us. Those kind of ongoing assessments, like the end of rotation assessments, are incapable of differentiating mastery at different levels of different competencies. It just can't happen. And so, in my view, at that point, the model fails. To conclude this, but I'm not going to quite conclude yet. I don't think we're ever going to be able to measure these things with sufficient precision to deliver on the promise of having some residents complete some things early and other things late. And maybe that's a good thing. Maybe that actually is a good thing, because after all, think of the logistical nightmare, because residents serve two roles. One is to learn, and two is to look after patients. And if we had residents coming and going willy-nilly on the fly and could not schedule them in advance and could not figure out who's going to be here on Thursday, the patient care situation would crumble around it. It would be a chaotic nightmare. So maybe, however counterintuitive, maybe it's not a bad thing that residents hang around for fixed time intervals. That's about the only way you could possibly staff the inpatient and outpatient settings. So perhaps it's a good thing that the emperor has no clothes in this regard. But the fundamental notion, what really I enjoy, is, as often the case, who's really bought into this? The administrators. They figure we can turn these folks out sooner, we can get them out of our hair sooner, we don't have to pay them so much, this is going to be wonderful. No, it isn't. First of all, it's going to take an enormous logistical superstructure in order to do any of this kind of measurement. Secondly, even if you can do it, my argument is that you're never going to do it with sufficient precision to deliver on the promise anyway. So is there any point? Strangely, the answer is yeah, there is. I think there is. And I'm not just doing this to get the paper published in the ACGME journal, which I did. I'm doing it because I think it maybe is drawing attention to something that's important. And that's this. First of all, it might be very important from a curriculum design point of view. Many educational interventions, it's the side effects of the drug that's more important than the drug itself. By sitting down with people and saying, here's the competencies that we want residents to have when they leave here, whether or not we measure them, the fact that we've defined them means that we can do things like ensure that everybody has at least experiences that would lead to those competencies. Instead of just turning them loose on the neonatal ward and never seeing a kid with asthma, we can at least say that these are the kind of competencies we expect, and these are the kind of experiences we're going to have to offer them in order to ensure that they at least are exposed to learning those competencies, whether or not we can measure them. The second point is this, that whenever we put together a final exam, there is no pretense that the Medical Council Part 1, with its 300-odd questions, represents all of medicine. It doesn't. What it represents is a very carefully chosen sample of all of medicine. A very carefully chosen sample which, like every statistician can say, can generalize to all of medicine. And the statistics of the Medical Council Part 1 exam is quite astonishing. If I haven't bored you with this before, the best predictor of performance in practice as measured by either lawsuits or peer review is not the Part 2 practice exam, it's the Part 1 multiple choice exam. It does a much better job of predicting performance 10 years later than the Part 2 exam. But it is deliberately a sampling strategy. It makes no pretense of measuring all of medicine. Maybe that's what we should be thinking of in terms of this, that what this is drawing attention to is likely that we are not assessing residents sufficiently frequently. Now, it's set such a hurdle that we could never possibly achieve that hurdle of assessing them enough to deliver on this promise. But nevertheless, what it's doing is drawing attention to the fact that residents aren't assessed frequently enough. So maybe what we have to set in place, and I think Sherman has actually done this, is essentially deliberately put in place a sampling strategy, where we make no pretense of seeing you on every competency and giving you the good housekeeping seal of approval on every competency, but rather we say we're going to assess you on a sample, and that's going to enable us to judge whether you're okay overall. And we make no pretense that we've assessed everything, just as we do with every multiple choice test. maybe that's not such a bad thing. And in fact, there's a little bit of evidence that that's a good thing to do. This is one place where they introduced CanMEDS roles into a residency program. In orthopedics. Now, arguably, that's an easier place than just about anywhere else to do this kind of stuff. But what they looked at was not the reliability of the measurements or whether residents graduated sooner or whether the thing was more efficient. All they looked at was the number of assessments. And there was a dramatic change. From an average of 7 assessments per year or so under the old regime to an average of about 25 to 30 assessments per year under the new regime. Maybe that's good enough. We do have a duty to assess our students as they go through. Assessment directly leads to learning. Maybe that's sufficient. So I think CanMEDS rules may not be totally misguided, except that in their hardcore form, it's completely unmanageable. But if we take it as guidelines rather than commandments, and create an operational model which takes some of the principles but doesn't try to fully implement the full ball of wax, we might end up with something that actually is fairly useful. Unfortunately, what we have to do then is wrestle the Royal College to the ground. What's the latest now? CBD is the latest iteration. Competency by design. More jargonism. But hopefully we can get around that and do something useful. And that's it. Thank you. Hope we can have some discussion. But I have to close it. Remember, I was a physicist. So lest you think I'm a pessimist about all this, this is a quote from my favorite physicist friend. I almost met Oppenheimer when I was here as a graduate student. He beat me by a year. The difference between an optimist and a pessimist is that the optimist believes this is the best of all possible worlds, and the pessimist is afraid he's right. Thank you. That's it. Thank you very much. Questions, comments? You must have comments. No? Yes. That's the undersilliness, isn't it? Yeah.
You spend a lot of money.
Yeah.
What's the evidence that implemented the CANMEDS strategy that led to better medical practice and performance?
Oh, God. Not a shred of evidence. You know that.
Well, isn't that an important question?
Undoubtedly it is, but I don't think that the Royal College is in a position to bother trying to answer that. I mean, excuse my cynicism, but it's in general, I have to say that in general, I don't like being forced into a notion that I have to prove that everything I do educationally shows up in patient mortality rates. Now, there are interesting cases where it does, but that's a very, very tall hurdle to overcome. But for something like this, which admittedly is costing bazillions of dollars in airfare, if nothing else, yes, I think it's reasonable to demand some evidence that surely the residents would now be performing better on the Royal College exams, even if we can't show a difference in mortality rates. Do we have any evidence of that? I don't think so, do we? I'm looking at other people who might be closer to it than me. But I mean, that's a reasonable demand to make. Do I think it's going to happen? Not a chance. No. This isn't the kind of intervention that's going to be educationally useful. Well, I think you begin by, yes, you're in an MHPE program? Yeah. Oh, that program.
And I put them all onto the Rotor portfolio, and then at the end of the day, I'm going to submit that
Competence in education related to transfusion medicine. Oh, okay. Anybody seen the movie about Alan Turing lately? The Turing test for artificial intelligence is, I don't remember whether it was mentioned in the movie or not, but basically you have two holes in the wall, and each one of them you have a computer hooked up to it. And you can ask the thing any question you like other than, are you a computer? And if you can tell the difference between the person at the other end of the wire typing and the computer typing, with me it'd be easy because there'd be so many typing errors, it's a dead giveaway, but that's another story. Then that's the Turing test for artificial intelligence. Interestingly, it's been started since 1950-something. Finally, 2 years ago, an artificial intelligence program passed the Turing test. They fooled the judges. Now, I think it's a bit of a cheap shot because that was a simulation of a 13-year-old Hungarian teenager. And so, like, all you got to do, is like talk like this, and like it's easy, nothing to it, but they passed the Turing test. Well, the normal Turing test is, okay, you've done that program. Let's put you alongside somebody else who hasn't done that program. And I can ask you any question other than, have you done that program? And what do you have going for you that they don't? What questions could I ask you to say, yes, that's a graduate of the program. She's achieved these competencies. I don't know what the answer is, but it's an interesting way to think about the question, at least. Because it really focuses on the outcomes of the educational program. Not patient outcomes, but student outcomes. That's what I'm arguing for as well. Clearly not. I mean, one of the things that gets talked about in the literature but isn't voiced in public is that when they started introducing CBE, the big deal was this isn't your behavioral objectives, this is different. But when you peel back the layers of the onion, no, it isn't. It's not different at all. It's the old behavioral objectives, and they fell because they were just, it was too arithmetic, it was too mechanical. And a physician is not just the sum of her parts. There's more to it than that. And furthermore, this sets the lowest hurdle. Okay, I got 51%, I can move on to something else now. So this has all sorts of structural problems. Pat, you want to say something? Brian?
I'm concerned about what would be impact on the famine, or whatever. I've got this huge inventory of competencies to acquire in a time frame, even if that's flexible. It's going to be hard work to get done. It's highly prescriptive. I don't have any choices. I have the menu.
Yep, absolutely.
And then at the end, I can see the set of competencies. I'm concerned about two things. One is that set of competencies actually a standard that we really want to see? Are we manufacturing widgets?
Yeah, exactly.
It all has to be the same, or can there be diversity in the product? Dave Sack has pointed out many times that the competencies you graduate with don't last. What's far more important is to teach people how to acquire new competencies, be inquisitive and inspiring through their practice lives. And I don't care what they started with. I know I'm 70 now. The competencies I graduated in 1969 with, many of them are worthless now. And many of the competencies I have now weren't available to be learned at some time. So it's been much more important in my career to how I acquire knowledge and skills than what I graduated with.
Well, you've written about curiosity, as I happen to know. I haven't read it, but I will. Okay, I think this wasn't supposed to be a public confession. But it's hard to imagine anything called curiosity in this mix. You know, it's just going to be page 300. I mean, this is like behavioral objectives, and I'm old enough to remember when that held sway in medical schools. And one of the standing legendary jokes was that Southern Illinois University had their book of competencies of behavioral objectives that was 451 pages, line by line by line by line. And the students just started at page 1 and kept going for 450 more pages.
Ignorance that in the first century of the millennium, the mind is not a vessel to be filled, but a fire to be kindled. That's our real.
For sure. And the people like Barb Miller and you guys who did that so superbly, and that would get lost in the shuffle. Brown? No. What? Yes? Okay, I'll retract the comment about Air Canada. Your conclusions are exactly the same as my conclusions. So then the question becomes, are we better served by setting up this utopian view, which I've talked to enough faculty members, enough clinical supervisors who are really very discouraged by the whole process. Is that the way to proceed, or would modest and doable proposals achieve more in the long run? Sure it is. But I don't hear any discussions about the modest proposals, either in Canada or the U.S. Yep, absolutely. Sure. Yep. And?
So I'm wondering, so what Brian said there is exactly right. The supervisor is trying to manage, in our case, a team of 30 to 40 cases. Be responsible to those cases and because the position is your primary cases while following all this evaluation stuff, up 10 to 12 women at a time who are book call, not on call, waiting on applications. These women are hard to keep track of. So she's going to be very, very daunting. So, but it seems to me we should come back to the core. What is feasible and relatively meaningful to you, and then how to, in saying modestly, trying to expand upon that.
Well spake. I can't resist telling you about a study that was done in South Africa, a guy named Matheson, who you said you can't even remember their names. Well, he did a study on that. He mailed out the ITER equivalent forms with the names of fictitious residents to the various clinical teaching units. 20% of them were completed, and 80% of them were above average. I think your point is absolutely well taken. That essentially, you're in a pressure cooker environment. Your goal is really to say whether this resident is competent or not. As an educator, I'd like to see you spend more time observing residents. Of course, I would. That's a nice thing, but maybe that's even that's icing on the cake. The question that comes back to the question raised before is, well, one is, does putting this place, trying to impose this entire incredibly complex superstructure, is that making things better or worse for you? Is it moving, because you're moving 5% towards along that way, and that's about all you can do. The second question you raise, I think, is also very interesting. Should we as educators, rather than be telling you what you should be doing, figure out ways that we can do it for you, recognizing the environment you're in? And yeah, you know, the center of the daisy is a medical expert. And a medical expert is a medical expert because she knows a heck of a lot about medicine, both formal knowledge and experiential knowledge, and that's, as you know, my research theme. And yes, we can measure a lot of that with a good multiple choice test. It's not the test that's magical, it's the fact that knowledge is magical. And knowledge remains key and central to your role as a professional. So of course other things like communication are important. But, you know, well, my favorite study that I might have mentioned the last time I was in this position, John Norsini follows up 10,000 heart attacks in the state of Pennsylvania, follows them into coronary care units, looks at the 30-day mortality rate, and looks at it as a function of whether the physician was certified by the American Board of Cardiology or passed or failed the exam. They all went through residency. They're all cardiologists. Some of them passed, some of them failed. And the guys who failed the multiple choice exam had a 20% higher mortality rate than the guys who passed the exam. That's as good as you know, as pretty well any cardiovascular drug in your pocket. So, yeah, boy, does knowledge count as a matter of life and death. So maybe what we should be doing is saying, how can we devise, I mean, we use video simulations for medical school admissions. Why don't we use video simulations for residency assessment? We could use simulation far more intelligently as part of the curriculum rather than as an add-on. And we don't have to use the $100,000 Harveys to achieve what we need to achieve. You know, if the Royal College ever hired me in my dotage, I'd be thinking along these lines about essentially creating a supplementary curriculum to offload your efforts onto standardized strategies. What's your name? Yep. Yeah.
So essentially, what a lot of us do is I have been trained.
That's all you have.
And I sort of say where those 5 points stay with it. I choose 1 point and then I randomly.
Yeah, I know you do. To show you're awake.
I know it's got whatever on the page.
Yeah, of course. I've often claimed the supervisor did that, but I never had anybody confess before.
And you're right. And you know you can simplify because some things are unfillable with the easier.
Yeah.
You know, all kinds of principles, I could repeat objectively assessment.
Yeah.
whole area. And then you generally get an impression, especially if I know what the history, communicate, the results tell you that the shop doesn't turn out what you call some very general impressions. And the other thing is subscription. We are in interaction with questions for one. I think they are cold calls, they are on the way, so you usually see them at most. Something with that.
You juxtapose the kind of blueprinting they're talking about against the reality that we're talking about. It's such an incredible mismatch. It's unbelievable. But the trouble is it has the illusion of simplicity. There's only 7 lines there. It used to be 14. This is an improvement, isn't it? But it's not. What's a collaborator? How the hell do you know that? What's 4 out of 7 on the collaborator list? I don't know. Thank you for the discussion. That was really good.